So thank you so much, everyone, for joining us today. I'm so happy to have everyone here. Just want to introduce myself. Sorry, I'm doing double task, entering people into the webinar and things like that. But my name is Giovanna Mozo, Director of the Hub. The Hub is the Regional Behavioral Health Action Organization for Southwestern Connecticut. So we are a strategic partner in 14 of our communities from Stratford all the way down to Greenwich. So we're really happy to have Shobha here today to talk about the trends and characteristics of unintentional drug overdose deaths in our region. So I'm going to pass it on to Shobha, and thank you again, Shobha, for doing this for us.
Thank you very much. Good afternoon, everyone. My name is Shobha Tangada. It's easy to spell my name and pronounce my name. If you remember Thank God, you will remember Tangada. So I'm from Injury and Violence Surveillance Unit, Department of Public Health, Connecticut. So I'm an epidemiologist, and then anything related to drug overdose data and CDC-funded overdose data to action grant information, you can reach out to me anytime. My email is provided in this slide 1. And I just want to make a note that I will be sharing these slides right after my presentation, so you don't have to note down anything. Just remember and go through the data clearly. So the learning objective today is, are the slides forwarding? Okay. Happening.
It did not advance.
Why? I think you may have to do that, so from my end, it is not forwarding.
Okay, I can do that.
Can I stop sharing it?
Yes.
Yeah? Yeah. Okay, can you please? Why I'm having all these technical issues today, I'm not sure, okay? Anyway, second slide, please. Second slide, please. Yes, yeah. So today's topics, they are not limited to, but I'm going to cover about the fatal drug overdoses in Connecticut and specific to Region 1, Southwestern Connecticut. Then also the impact of COVID-19. As we all know, COVID has changed our lives the last 3 years, so is the drug overdose numbers. Then also I'm going to talk briefly about the substances involved in the drug overdoses, and demographic data, and the circumstances, which is a very interesting concept of looking into the drug overdoses and looking into basically the lives of each decedent. Then also I'm going to talk about what DPH is doing through the CDC-funded grant, which is called as the Overdose Data to Action Grant, the prevention strategies we are following to check these drug overdoses in our state. Then also the surveillance strategies, how we are able to do the surveillance 24/7, 365 days through the epicenter, then also the OD through the OD map. And data-driven prevention efforts, say, hey, we have the data, so how are we going to address the issues and how the prevention strategies can be changed based on the data which we are getting through the OCME, which is the Chief Medical Examiner Office, because data speaks and our decisions have to be made on the data which we are getting. So, and also after you get the data and the numbers every week and every month and every day, from the OCME, so how we are disseminating our data to local authorities, which are like local health departments, prevention committees, and then also the opioid task forces. I'm going to talk a little bit about how we are reaching out to people who have the boots on the ground. Next slide, please. Next slide. Okay, so yes. So I mean, this collaboration is a very key part of our. If you want to reach any goals, the collaboration and the teamwork are the key essential tools to get the results what we want. So at the end of the DPH so we do collaborate with the multiple agencies and the prevention committees to just to name a few. I just gave a list of it, and each one of these committees are very, very important and very, very useful to derive at our decisions to make the prevention strategies. To just to name a few, this is the OCME, which is the Chief Medical Examiner, is our data source, so we get all the information about the drug overdose deaths. Then also local health departments and the prevention committees and the opioid task forces, our boots on the ground. So we, as a DPH member, I will not reach out the communities, but we have a ways to reach into the communities through these local health departments. And then also we collaborate with the harm reduction through the syringe exchange program, Planned Parenthood for the neonatal abstinence syndrome, the mothers who are going through the treatments and whose babies are affected with the drugs. Then also the ADPC Prevention Committee, which has associated with the mental health department, and then which we get the information from them and we provide the data all along. And the New England High Intensity Drug Trafficking Area, which is simply called as NE-HIDA, and where we get the information about the new substances which are flowing into the Connecticut from our neighboring states. So these are just to name a few of the agencies which we collaborate heavily on day-to-day basis. Next slide, please. So as I mentioned, our main data source is from the Chief Medical Examiner Office, and then also we use the SUDARS data. In short, it is called as a State Unintentional Drug Overdose Reporting System. So briefly, this is the name for the SUDARS, and then I will be going in detail how the SUDARS data helps us to make our decisions of the prevention strategies. Next slide, please. So as we all know, so impact of the drug overdose deaths on the communities, on the families, and the friends. So just to let you know, 9,226 deaths have happened on accidental overdoses between the 2012 and 2021. You are hearing right. This is like a 9,000 plus people. On the top of it, 2020 is not slowing down. We already have like 903 confirmed deaths, and we have several hundreds of pending cases waiting for the toxicology confirmation. So now, looking at the numbers, how bad it is and what we can do together, to bring these numbers down. Next slide, please. So this landscape of this graph speaks it all, what is happening in our state from 2012 to 2021, and we are not slowing down in 2022 either. So this is a perfect ascending slope for a very, very wrong reason. In 2012, as you all know, the Connecticut population remains the same, around like 3.5 million people. But look at those numbers for the same 3.5 million people, which we were 357 deaths in 2012, and we have reached 1531. And again, as I mentioned, 2022 is not slowing down either, So especially if you look at the right from those three tall bars, from 2019 to 2021, that is the impact of the COVID I will be talking briefly in a short time. Next slide, please. Did you advance? Okay, this is a very busy slide. Don't remember anything. I just wanted to let you know, if you look at the left side of the slide, those are all the substances or the combinations which have been involved in the drug overdose deaths in the state of Connecticut. And I have simplified this slide in the next slide. Next slide, please. So this is a simplified version of the previous slide. So this tells you all about the different substances which were involved in the deaths. This is the percentage of the deaths from 2012 to 2021. If you pay attention to the top blue line, that is the percentage of the deaths involving any opioid. When I mention any opioid, it could be illicit or the prescription drugs. So as you know, the major chunk of the drug overdose deaths are involved with any opioid, which is like a 93%, for example, in 2021. So the other line which you need to pay attention to is that dark red line, which is the fentanyl, which we are talking about. Fentanyl is a synthetic opioid, which is taking part about 86% of the deaths are involved with the fentanyl in 2021 alone. If you look into the up to 2015, we were just in the range of like 25% of the deaths were involved with the fentanyl. But after 2015, slowly it started creeping up to like 86% by the 2021. And again, in 2022, it's the same percentage, about 85% of the deaths are involving with a synthetic opioid, which is the fentanyl, or we call it as illicitly manufactured fentanyl. Next slide, please. So briefly, I'm going to talk about the impact of the COVID-19, which is the years of the 2019 to 2021. Next slide, please. Okay, these are the numbers to the left. These are the numbers from 2019 to 2021. In 2019, we were at 1,200 deaths, and which is creeped up to 1,531 by the 2021, which is the COVID year. And so is in 2021, also we had a much higher number than 2019. So basically, over the 20 and 2021 compared to 2019, we had about 27% of the increased deaths. So I gave the breakup in the little boxes in the middle of that slide. And also, as I mentioned before, January to September 2022, we had 903 already confirmed with the toxicology, but several hundreds of cases are still being pending for waiting for the toxicology information. So once we know that number, definitely it will increase through the September. And we still have November, December, October. You know, I think projecting annualize the data, I think I should say that we will be somewhere near the 2020 numbers, like around like 1,400 for 2022 also. That means we are not slowing down, and our efforts of the prevention work needs to be really picked up, and then, you know, we have to keep the momentum with our prevention strategies. Next slide, please. So where are all these people dying? You know, so I mean, just to give a brief note, as you see, major chunk of like 60% of the deaths are happening in a residential setting. That could be the decedent's own resident, or the family, or the grandmother, grandfather, the boyfriend, girlfriend. But basically, it is in the residential setting. The 60% of the people died in 2021. And next is the hospital. You know, the percentage, as you see in 2021, about 26% of the people were able to reach the hospital. And they got some kind of treatment. It could be like an inpatient, or it could be people died at ER, or it could be dead on arrival. You know, sometimes, you know, when the EMS goes to the scene, you know, if they have some little hope when they are still working on the decedent, they reach, but, you know, by the time the person is reached to the hospital, the person is already dead. So it could be inpatient, or the ED, or the dead on arrival categories, which falls under that percentage of the hospitally reached decedents. And the next major thing, you know, so what I noticed, you know, so like there were more deaths in 2021 and 2022, 2020, and also 2022 in the hotel setting, you know, so means people, they were not, because of the stay home orders or whatever, you know, so because of the COVID situation in 2020 and 2021, people were not doing the drugs, but they were doing elsewhere, majorly in the hotels, you know, so, and then people died in their room which they rented, you know. So this tells you that we need to speak to the hotel management and somehow make that naloxone being available in the hotel systems also, which DPH is working on it. So the other places, people, you know, when they don't want to do the drugs at the hotel, or when they don't want to do the drugs at residence, you know, so people did in the parks and, you know, so abandoned buildings, you know, so just some out of the dark areas, you know, so under the bridges. And then people did those drugs there, and then unfortunately they were not being helped, and they didn't survive. That is the other category, which towards your right side. So next slide, please. So this is the monthly graph of the overdose deaths, you know, so which speaks for the 2019 to 2022 August. So by the month, as you see, you know, the COVID has started around 2020, March and April, you know, so as you see in the April of 2020, that's when we started seeing the higher numbers of 133 people died in that month. And then it kept the momentum all through, you know, so and then we are still not slowing down in the September of the 2022 also. So since I'm going to share these slides, you can go through those numbers and look into those monthly numbers at your own pace, at your own leisure. Next slide, please. So this is the monthly average. Again, to talk about the impact of the COVID, the average number in 2019 for month was 100, and then we reached in 2021 about 128 per month average number. And in 2022, we are at 100 as of now, but that number is subject to change because we have pending cases, and we may be something like a year of 2020. I think so. Next slide, please. So this is the percentage of the fentanyl involved deaths. As you see, even the fentanyl is present all along from 2019 to 2022 up to today. So, and the average number of percentage of the deaths which are involved with the fentanyl is around like 83 to 85%. That hasn't changed, So, if fentanyl was present in 2019, fentanyl is present in 2022 also. Next slide, please. So this is xylazine, so I would like to touch base with the xylazine number. So as you all know, xylazine is an animal tranquilizer. People add the xylazine as the additive to their opioids or the stimulants because it gives another kind of kick to the drug to people who are using it. So something to pay to attention. Xylazine is not intended to use in human beings, but somehow the drug dealers are mixing with the either with the fentanyl or with the cocaine or with some other substances. And just to make a point, elsewhere in the northeastern northeast area, so Connecticut is very unique. All the fentanyl deaths were involved with in combination with the xylazine, so where elsewhere, so I think, for example, in Massachusetts, the fentanyl was, the xylazine was contaminated with cocaine. But in Connecticut, whenever you see xylazine, it also had the fentanyl, something to keep in mind. And we are keeping track of the xylazine presence, and we are communicating with people. And recently, I also published a paper in MMWR with the CDC journal. So we brought it to the notice of the nation why the xylazine numbers are so high in Connecticut. Next slide, please. So this is, again, I would like to, this is a slide which I have shown you before. Our major culprit is any opioid, which is meaning the prescription or the illicit opioid. And the fentanyl is the big culprit, having the 86% of the deaths in 2021. And then also something to pay attention is the stimulants, that the light green is are rising in Connecticut, something to be need to. Stimulants, when I mean stimulants, it's cocaine or meth or the amphetamine, so those are in increase, the percentages is increased. And the good news is the light parrot green, which is sliding down, that is the heroin. And the heroin deaths, not only in Connecticut, but also all over the nation, the heroin is coming down. But whereas the synthetic opioids are picking up and the stimulants are picking up, something we have to pay attention to. As I mentioned, we constantly work with the drug monitoring initiatives from the Homeland Security and then also the New England HIDA for all the new substances which are floating into our state. Next slide, please. So what happened, so what are the changes which were being brought about during the COVID years? The percentage of any opioid involved deaths remained very high, which is around like 94%. And then also the fentanyl remained very high. It could be ranging between 82% to 86% of the deaths were involved with the fentanyl. And then the cocaine was on the rise. And then also so is the xylazine involved deaths were on the rise. And we saw the 3% increase in methadone involved deaths because, because of the stay-home orders, the methadone was given from the clinics to the take-home, so doses, and then probably they were misusing their methadone dose. And then we saw a slight increase in the methadone involved deaths. And the good news is the heroin is coming down, not in Connecticut alone, but also throughout the nation. This is the inference which we made during 2019 to 2021 overdose deaths. Next slide, please. So I think the other question which people have on their mind is gabapentin, because people are reaching out to me from the local health departments. Gabapentin, gabapentin, gabapentin. Is anything? See, one thing I would like to highlight is even though the gabapentin was involved with the overdose death, I have not seen just the overdose death happen just by gabapentin itself. When the gabapentin was present, so some other substances were also present in the system of the dissident. And yes, we do agree, if you look into the 2018, so there were barely 7 deaths involving the gabapentin plus some other substance in the system, but that is increased to 86 in 2019, and in 2021, we had like 179 deaths, which is barely about 11% of the deaths were involved with the gabapentin. But we are noticing that, and we brought it to the attention of the DCP, who monitors the prescription data. So from the physicians, and they started monitoring the prescriptions written by the physicians from 2021 onwards, and then we are keeping an eye. Are the dissidents grabbing this gabapentin, or it is illicitly mixed with the illicit drugs, or it is a prescription increased by the physicians itself. So we will have some answer probably in next few months, because we will have one full year data from the DCP of the prescription information, but something to pay attention to. Again, gabapentin is not a controlled substance. It does not kill by itself, but when it is mixed with the opioids, so which people dependent are taking, it may cause a respiratory depression, and then, people may die out of the combination of the opioids plus gabapentin. But just gabapentin alone will not kill the person. Next slide, please. And I also gave a reference of the CDC, which is published recently on the gabapentin deaths in our state, USA. So we are also paying attention to the presence of marijuana and then also alcohol. As you know, the Connecticut legalized the marijuana, and then we are paying close attention with collaborating with the DMS, so they have a whole lot of the education material weaving around the marijuana, so we were a part of it too. And then we were helping them with giving the presence of marijuana in the overdose deaths. You see the numbers on the next slide, please. So this is the percentage of the marijuana towards the left, those 3 bars in 2019 to 2021. So about 28.6% of the deaths were involved. Marijuana was also present in the drug overdose deaths. As you know, marijuana is never considered in the cause of death from the chief medical examiner. But when we look into the toxicology of each individual, we would know the marijuana was present or not, going through the toxicology, but it is not in the cause of the death. So the next one which we need to pay attention is alcohol involved, so that means illicit substance, marijuana, or alcohol. So alcohol is oftentimes, if it is more than the blood alcohol level range is exceeded X amount of the alcohol percentage, so it is mentioned in the cause of the death, but the marijuana is never mentioned in the cause of the death. So the next slide, please. So we are paying attention to, so since marijuana is legalized now, and we are paying close attention to the presence of marijuana in the drug overdose death. So next, I will be diving into the demographic data. Who are these people? So first, I will talk about the state of Connecticut demographics, and then I will jump into the Region 1 drug overdose deaths and the demographics of the data. Next slide, please. So this is by the sex, so as you know, about 75% of the deaths are for the males, so drug overdose deaths, and then about 25% of the deaths are in the females. And this slide specifically projects the rate for the 100,000 population of the specific either males or the females. As you see, from 2019 to 2021, the rate has jumped from 52.6 to 64.2. And so is in the females, from 15.7 to 22.7. But one thing you need to pay attention to, it is increasing in both males and the females, but the rate of increase is more in females, so which we need to pay attention to. We got the point, and then we are looking into how specifically we have to reach out to the population of the females also, So next slide, please. this is by the race ethnicity, so something we need to pay attention to, so as you see, we are seeing a big racial disparity here, so that light blue is for the black and non-Hispanic black. So then also that light green is for the Hispanic. So as you see in Hispanic, let's take the example of the black non-Hispanic. In 2019, the rate for the drug overdose deaths was at 33, and which is jumped in 2021 for the same population, 48.8. And if you look at the extreme bar for 2021, that light blue, it is 70. The rate is at 70. So that means in the black, non-Hispanic black population, we jumped from 33 in 2019 to 70 in 2021, the rate. So, I mean, we brought the attention to the CDC, and then elsewhere, everywhere in the nation, we see the same results. For some reason, the overdose death rate is increased in the black non-Hispanic population and then also the Hispanic population. Maybe we need to create a special education method, or special prevention strategies for this kind of race ethnicity specific populations, and we got the notice and then we are working on it. So you also, you keep this data in your mind when you reach out into your communities, so how best you can serve these communities. You need to make a strategy of the prevention. Next slide, please. So this is by the age, so as you see, the bigger age, so I mean, we think as the people grow in age, so they become more sensible and they are more pay attention to what they are taking the drugs, so how responsible they are. But our major age group, if you see 35 to 44 and 45 to 54 and 55 to 64, all these age groups are most vulnerable for the drug overdose deaths. So, unfortunately, so under the 25 years old, we don't see that big rate, so which is only at 6.1. And that is also creeping up, during the COVID years, so we need to pay attention to. So, but, the major groups are 35 to 64 age group are the most vulnerable for the drug overdose deaths. Next slide, please. And also, I just want to go back and then mention on the age, so today, this morning, I was talking to the child fatality review, and I was really surprised, so we had in 2021, we have 6 children under the age of 2 years have died because of the fentanyl intoxication, so they were not considered as unintentional drug overdoses, but they were considered as a homicide because the parents were involved. I was really, very sad when I heard those numbers, so we had 1 death in 2020, 6 deaths in 2021, and 1 death in 2022 under the age of 2 years, which is very, very sad. So this particular slide is by the county. As you see, the New Haven, the Hartford, and the New London have the maximum number of deaths, of the drug overdose deaths. So I think Fairfield is doing pretty good. So even though you see increase, in 2021, I think the rate was at 24.8. So, but the highest rate is in New Haven, New London, and the Hartford. Next slide, please. So, in what is happening in 2020 during the COVID years, the drug overdose deaths have increased in both males and females, and then also compared to the white population, the Black and the Hispanic populations were dramatically increased during the COVID years. And then stimulants, cocaine and the cocaine plus fentanyl deaths have increased, whereas the heroin deaths are decreased. And identifying the gaps and the prompt data dissemination and the collaborating with the multiple prevention partners are the crucial components to prevent the drug overdose deaths. Next slide, please. So let's dive into the Region 1 data, which is the Southwestern Connecticut. Next slide, please. Okay, towards the left side, you see the bars, which I categorized, and towards the right side, you see all those towns which are involved with the Region 1. which was provided by you. So I just quickly analyzed the data for by the town and then also the total number of the deaths which happened in the Region 1 from 2019 to September 2022. In 2019, Region 1 had like 108 total, and as you see, the Bridgeport had the maximum number, followed by the Norwalk and then the Stamford. So again, that number 108 jumped to 136 in 2020, which is a COVID year, and to 150 in 2021. And then so far in 2022, we have like 82 deaths, and that number will increase because these are confirmed, but we have several pending cases, So your maximum number of the deaths in Region 1 are happening in Bridgeport, Norwalk, Stamford, and then Fairfield, and then also Monroe, So something I think you will know better how to bring about the preventive strategies in these particular towns where they have the highest number of the drug overdose deaths. Next slide, please. So this is by the location of the death. As you see, the statewide data tells you that the maximum number of deaths are happening at the residential setting, and so is in the Region 1. So there is no change. So I mean, like a maximum number of deaths are happening any given year at the home setting. So that means what I mean to say is you have to distribute that naloxone to the family, friends, next of kin, the close acquaintance of the dissidents, you have to identify and then distribute that naloxone heavily, so that people who are in the immediate premises of the dissident, a person who is using the drugs, can be being helped by those people who has the naloxone. So the next setting is the hospital, so again, as I mentioned, so people are reaching out to the hospital, but unfortunately they were not being survived because of the potency of the fentanyl. You barely have any time once you take the fentanyl and the person gets into the respiratory distress, so there is barely any time to survive, so that tells you the importance of the naloxone to be distributed into the communities heavily than what we are doing today. Next slide, please. So again, Region 1 is no different from the state of Connecticut. The maximum number of the deaths are involving fentanyl, as you see the first 4 bars from 2019 to 2022. Next is followed by the cocaine, as you see, and the next bar is for the heroin. And the heroin is coming on the decline process, throughout the nation, So that I'm not really concerned with the heroin. I think soon the heroin will be a thing of the past, So I'm thinking so, So looking at the data. So the xylazine, again, so in the Region 1, I think we do see quite a few number of the xylazine involved. That's, So as I mentioned, xylazine is always in combination with the fentanyl, and the fentanyl is on the rise toward, as you see in those bars. And again, gabapentin, I just gave you the statewide data, and then these are the numbers for the gabapentin in the Region 1. Again, nothing to be alarmed about the gabapentin at this point of the time, because gabapentin is being prescribed by the physicians for a number of clinical reasons, so it could ease the nerve pain, and then it can also, to an extent, it can serve as an antidepressant, so I mean, like multiple uses for the gabapentin, so, and anyway, the DCP has the notice of this gabapentin rise in the drug overdose deaths in general, and then we are keeping track of the number of the prescriptions written, and then they are monitoring since 2021, and then we will have 1 full year data soon in 2022, then we will be able to put the prescription data together. Next slide, please. So by the sex, again, Region 1, just like in the statewide data, so the males have the maximum number of deaths, and then followed by the females, 75% versus around 25%. And then when you look at the age group, Region 1 is no different again. It is just like the state of Connecticut data, so between 25 to 64 are the major groups who are having the maximum number of the overdose deaths in any given year. Next slide, please. So again, as you see, the blacks, non-Hispanic blacks have the maximum number of, there is a huge increase. I can't say But when you calculate, these are the numbers which I projected here. But when you do the rate, so definitely the Black, non-Hispanic Blacks will have the higher rate compared to the white non-Hispanic people. And then, for example, let's take the orange bar. So in the 2019, there were like 17 deaths of the Black non-Hispanic people in the Region 1, and which is increased to 28 in 2020, 43 in 2021, and then we already have 30 in 2022, and that number will be changing because of the pending cases. So when I calculate the rate, which I haven't done here, these are only the numbers I'm projecting. As I mentioned before, so the Connecticut data, the population remains more or less similar year to year. So I would consider, so that number increase, which you see from 2019-17, which is creeped up to 43 in 2021, the rate also will increase for the Black non-Hispanic people, and then also for the Hispanic people, which are the light green. Next slide, please. So let's dive into the circumstantial data. Now we are all talking about the numbers, so every dissident, next slide, please. Every dissident has a story, because I read through the circumstantial evidence of each dissident, which comes from in the form of called as a CME narrative. When the scene investigator or the case investigator goes and talk to the scene investigation, and then also talk to the next of kin, could be a family or a friend or some other person, important person in the dissident's life. They gather all the information and they put it in the form of the narrative, which the DPH has access through the OCMA. So we put all that information together, circumstantial evidence, and then into a system which is called as the SUDAS data, which is like basically, it is the platform, CDC for funded platform, where we gather all the information about each dissident, each dissident. So this information, circumstantial evidence, will improve the timeliness and accuracy, and then also we can also identify the specific substances, because it has various tabs. It has a demographic tab, and then it has the injury tab, where all that information, how it happened, where it happened, why it happened, who was there at the time of the death, but did the person reach to the hospital or not, if the person was given the naloxone or not, if the person has any mental health issues prior to the overdose, if the person was already had a prior overdose and on the MOUD program. All this information which we put into the SUDAS system, and then we analyze the data. Basically, we look into the life of a dissident through the SUDAS data, including the medical history, substance use disorder treatment, and the criminal justice involvement, you name it, the whole 9 years of the information about each dissident we incorporate into the SUDAS system. Next slide, please. So the SUDAS data is very useful, as I mentioned, because we are walking into the life of a person, so we would know what is happening with that person. And when we put all the data together, so we can inform better for the risk factors and the specific circumstances leading to the overdose death. And then also looking into the toxicology, we would know what were the different combination of the substances involved with the overdose death, and also the impact of the overdose, so that we can make the changes of the prevention work, so because data always speaks. If your prevention strategies are based on the data, probably they are very useful rather than making a guesswork. Next slide, please. Next slide, please. So I analyzed we at the end of the DPH also analyzed the 2020 data. For example, I'm just projecting the 2020 data, what happened in 2020. And then also CDC also projected, analyzed this data, SUDAS data. If you look into the yellow box, it is amazing that 75% of the drug overdose death at least has one opportunity to intervene and save that person's life. 75% of the times we could have saved that person. How? Look towards the left side of the only 9.6% of the people have the current treatment program in place. That means what happened to the rest of the 90% of the people? So they were not having any kind of substance use disorder treatment. We could have saved by providing the MOUD program to them, probably we could have saved them. So 11.4% of the people who have witnessed a fatal drug overdose. If only they had the naloxone in their hands, probably 11% of the 1,500 plus people, just imagine 150 people would have been saved by giving the naloxone right away. So which was not happened. So 30% of the people had the mental health diagnosis. So they already had the problem even at the time of the overdose death, but were they given the help, mental health treatment? Were they given any MOD program provided? So it is a question, So I mean, that's definitely we can improve our prevention strategies by giving more help to those people. Then 55, next line is the long bar, is 55.5% of the people have the potential bystander present. When I mention bystander means in the immediate vicinity, maybe the person may be doing in a different room, but there was somebody in that household. So, I mean, maybe they may not be knowing, but they had a chance to intervene and provide that naloxone, So, that tells you, how vividly we need to distribute the naloxone to the family, friends, and the next of kin, and the other people surrounding the important people in the life of the dissident. So 10.7% had the prior overdose. Okay, they had the prior overdose. Why the second overdose or the third overdose had happened and the person was not able to be saved, or the person died of the overdose? When they had the first overdose, but they were not in the MOD program, or how come we were not able to help? These are all the different things, So I mean, where we could have been intervened to save that person. And the other one is 9.8% was just released from the institutional setting. It could be the institutional setting is basically released a month before the death, not a long time ago. When they were in the institutional setting, like a DCP or a happy house, So I think we think when the person is released from the prison, they have the full package of the treatment program, and then also the other help, so like a housing, and then also the finding a job for them, So for some reason, so they came out of the institutional setting and they died, So probably we could have taken care of them in a better way. That's my question. So again, so 31% of the people administered naloxone. What happened to the rest of the 70% of the people? Why they were not being helped with the naloxone? So I mean, by vividly distributing the naloxone, probably we could have saved those people. So that is something to keep in your mind, because you have the boots on the ground. So I mean, this is the data I am providing you. This is the real data from the investigator, of the scene investigator, and then also the scene detective. So this data is real. So something to keep in your mind when you are doing the prevention work and reaching out to the communities, you have to always think how we can make ourselves better in providing the services to the people. Next slide, please. So this is, again, the projectile of the previous slide. So I gave the percentages in detail, how many people have the housing instability, and how many were the relapsed people, and how many have witnessed the death, et cetera, et cetera. And then keep in your mind, you can modify your prevention strategies based on these percentages. Next slide, please. So again, one thing which strikes me is education data. I'm always pro-education, like we all do for our children. I got this data from the death certificate, which is real, very authentic. It's about 53.4% of the deaths in 2020 were, have barely high school graduates or the GED graduation. That tells you their socio-economic status, of the kind of job which they are doing. So we need to improve there also. So next slide, please. Next slide, please. Data-driven prevention efforts. What are we doing? So as we all know, fentanyl is the culprit. So we need to distribute those fentanyl strips, and then we need to advocate and educate people about the presence of fentanyl. Fentanyl by itself, fentanyl in pressed pills, fentanyl in oxycodone, fentanyl in cocaine, fentanyl, it is based on the heroin. It is omnipresent everywhere, and fentanyl is very, very dangerous. We need to reach out to the communities and then tell about the dangers of the fentanyl. And we are monitoring the gabapentin prescriptions, And then also something to pay attention to is the disparities in the demographic data. As we all know, I just mentioned before, Black, non-Hispanic, and Hispanics have the highest rate of increase, so which we need to pay attention to, and then reach out to those communities in a better way than we are doing now. Next slide, please. So the naloxone distribution, naloxone saves lives, as I mentioned, so we need to distribute more into the community so that the lives will be saved. Next slide, please. And the MOUD services need to be increased too, so right now, just barely about 30% of the people are being helped with the medication for the opioid use disorder. Next slide, please. So as I mentioned before, the CDC funded grant OD2A is our funding source, major funding source, and then we are doing our best of providing the funding to the local health departments who have the boots on the ground, and we from time to time we tell them about the gaps, and then we request them to improve the prevention work in their communities, because each community is different, each person's need is different. So we need to cater, and we are always ready to provide the data, specific data, which is, it could be the county level or the local health department level, so we are here to provide the specific data, and so that you will assess the needs and then you will do the necessary prevention work. Next slide, please. So these are some of the arms for the OD2A grant, which I just mentioned, so I mean, you can go through in details, and then you can reach out to me anytime if you have questions. Next slide, please. So basically, we focus on the 24/7, 365 days of the surveillance. So unless what is happening on the day-to-day basis, we would not assess the situation. For example, if every town in this Connecticut has a threshold level of number of overdoses per day, and when that exceeds, we get an alert from the epicenter, which is connected to the hospitals, emergency rooms. So when we see a higher X number of alerts for that particular town, we immediately reach out to the local health department. We tell them, let them know, hey, something is happening in this town, so could you please look into that? So those people will be alerted, and they will do the prevention work in their own community. That is a 24/7 surveillance strategy. Next slide, please. So then also, I mean, we think, I mean, it all started with the prescription data, but it is not the prescription drugs which are causing the problem, the overdose deaths anymore, because we do link the opioid prescription data to the dissidents. And then next slide, please. I would let you know, how low percentage of the dissidents have the actual prescription for them. And for example, this is a non-fatal data, which I put together sometime in June of 2022 for another talk, and I didn't have time to crunch the latest data, so definitely those numbers will be increased for the 2022. You see, from 2019 to 2022, we at least had like 17,000 people plus overdosed and then went to the hospital or the ED, so or the urgent care centers. So that means they had the overdose already, so fortunately they survived and they went home. So how many of those people were given exactly some kind of help which they need? That for the same reason I put those numbers in. 17,000 people from 2019 to 2022 July had at least that overdose as per the hospital records. Next slide, please. So those are the people which we need to grab and help them. So also, this is about the PDMP linking. We, based on the first name, last name, and the date of birth, we link the prescription data to the dissidents. Next slide, please. So these are about 70% of the people were matched with the DCP data system of the dissidents. Next slide, please. As you see in this graph, in 2021 and 2020 data, I put them together. If you look into the bars of the left side, only 7.9% of the dissidents have at least only one opioid prescription. So that means it is not the opioid prescriptions written by the physicians is causing the death, but it is illicitly manufactured fentanyl is causing the death in the community. Next slide, please. So next, then as I mentioned, we also collaborate with the Department of Corrections, and then we have stationed a nurse there, who monitors the methadone program and then also the buprenorphine program. Next slide, please. So we have put the data together from the 2020 and 2021. So as you see, between 2020 and 2021, we had like 2,733 total deaths overall. And in that, so DOC matches at least 1,297. That means we had about 47% of the match of the dissidents with the DOC correctional system. Unfortunately, I cannot provide the time frame. Is it like 5 years ago or 10 years ago? But at least 47% of the people were associated with the DOC. See, out of that, I have given you some numbers. In 13 out of the 40, about 30% of the overdose people within the 6 months of the release, they died. They had the MOUT program in place, but somehow, that was not working. Then also, about 70% of the people who were matched, they also died 6 months later. So that means we are providing everything to them, but the help we are providing to them is not help. It's being sustained, or what is happening with their lives, we don't know. But something, those numbers to keep in your mind, because these are the numbers provided by the DOC itself. Next slide, please. Then we also collaborate with the PPSNE, so which is like a Planned Parenthood of the Southern New England. And then because why I'm talking this is, in a minute, I'm going to talk about the neonatal abstinence syndrome, because these are the mothers and the babies who have been affected. Next slide, please. So this is the graph of the neonatal abstinence syndrome. That means the newborns which were born to the mothers who had drugs in their system. So as you see, from 2010 to 2019, we have hundreds of the kids who were born to the people mothers who are on opioids. So basically, it could be mother could be on the methadone, or mother could be on the buprenorphine, or mother could be on the prescription opioid for some other health reasons given by the physicians. But these are the people most vulnerable. We don't know. We cannot imagine the household of these people. So these are the newborns which were born to the mothers who were using the opioids in their system. Next slide, please. Next slide, please. So we have the complete data system, so our job from the DPH is to disseminate the data to the local health departments, stakeholders, opioid task forces, and the prevention committees, so that they can assess their problem in their local communities and do the needful job to their communities. And we are here anytime. Please reach out to us, so for any kind of data analysis you want, we are here, and we will provide you with no delay, so because our goal is the same. You are working for the same goal, and we are working for the same goal, and then we are here to help you with the data needs. And then also, all the reports are available on our DPH website. So if you need anything, so you can go to our website and take a look at all the reports. Next slide, please. Next slide, please. That is the link for, these are the monthly reports. Hopefully everybody is reaching these reports. So if not, please just send me an email, and I will be happy to provide these monthly reports, which are updated around the second week of each month. Next slide, please. And this is the line level data which we provide to local health departments, line by line without the identifiable information. Every month, this report is sent to the local health departments. Next slide, please. And then the interactive dashboard, which we have on our website, which is a very great tool, so, and we have the data from 2015 to 2022. You can grill the data by demographics, geographic data, and also the drug breakdowns, so you can just simply try to play with the dashboard very freely. You're not going to harm the dashboard because it is locked in. So, the more you use, the more familiar you get how to get your own town data. Next slide, please. Again, we try to update every month. This is the face of the tableau. This is how it looks. And then as you see towards the right side, you have all the years. And then you can grill down the data by filtering the data of your town, or the demographic data by the drugs, by your town, by the county, you name it. You can just play a lot with this. Next slide, please. So next slide, please. So timely data analysis, identifying the gaps, and the prompt data dissemination are the crucial components where we can, and the collaboration, active participation of the multiple prevention partners is also very important. And customized data report, we are here to provide to any jurisdiction so that you can assess your own burden in your own local community and make those good decisions. Next slide, please. So top priorities, so as you know, fentanyl influx should be monitored and then completely stopped. And then also pay attention to the fentanyl tips, and then stigma. We all should work towards reducing the stigma, create that hope, because the recovery is possible, and increase and enhance those MOUD programs. And timely actionable data to guide our overdose response strategies is also extremely important. Next slide, please. So it is a big puzzle. Once you put all the puzzles together, we can make a difference. Next slide, please. That is my slogan all the time. Together, we can make a difference. Everybody has the same goal, and we do care about the families and friends of the dissidents, and we want to reduce those numbers. Is our goal. So together, definitely, at some point, we can make a difference. I think I see a slight decrease. Good news. In 2022. The numbers seems to be lowering. Hopefully, I am correct. So I will bring the good news soon, So at least when I do the analyze numbers, so I think I do see some trend of the decrease in 2022, So hope for the best. Thank you.
Thank you so much, Shobha, for this wealth of information. We all really appreciate all of your hard work that you put into this PowerPoint, because it's a lot. And, I think that we need to continue to work together, like you said, right? We're all in it. We all have that same goal, is to save that life, right? I did have a direct question from someone that I'd just like to ask. The person asked, if we want data from suitors, who can access that information? Is it the local health department only?
Suitors data is accessible only to DPH, so unfortunately, because it has all the identifiable information to provide that link to you. But if you need any specific data for any of your towns, all those components which I mentioned in the suitors, I'm very happy to analyze the data for that person, So unfortunately, you cannot access suitors data. Okay. We have to analyze and then give you.
But that's really nice to know that we can reach out to you when and if needed to get that information. So that's wonderful. Anybody else have any questions?
Hey, this is Brian Weeks over at the Norwalk Health Department. Great presentation. Thank you for putting this all together. I had a quick question, because what really stood out to me in one of those slides in regards to opioids, and the opioid deaths, I believe, it was just that there was an initial connection with the physician that initially prescribed the opioids. And that was like, what, 70 or 80%, something like that with those numbers. I thought that really stood out quite a bit. And I don't know, Shobha, if you can kind of go into a little bit more detail. I might have missed that part, because I was juggling also the other DPH local health meeting at the same time. But I thought that was very notable. And then it also kind of suggests that, often it starts at the doctor's office. And, again, considering what else we can do in terms of outreach for that, or really just limiting the prescription of opioids, because that seems to be, one of those initial gateways.
Yeah. Hi, Brian. So as you mentioned, initially, once upon a time, definitely it all started in the clinician's office, but not anymore, because we do link the prescription data to the dissident data. As you see, barely like 7.9% of the people had the prescription in their hand, so that tells you, that is like within the 30 days of prior to their death. So, this is all fentanyl. As you know, the drug problem never went away, but we are noticing more because of the fentanyl is so dangerous and the deaths are happening. But it has been there. Cocaine was there all along, heroin was there all along, some other drugs were there all along. But it is the fentanyl, which is causing these deaths, So that's why we are paying more attention, So I would say the drug problem was there all along, but we are noticing more because of the fentanyl presence, which is causing the deaths. It is not the prescriptions anymore.
Hi, this is Kathy Hazel. I just want to follow up on Brian's question because I had a similar comment to that. So just to be clear, no longer are we worried about people are not starting with their prescription drug that runs out. They get addicted while they're on it, and so they move to a street drug. So we're not seeing that pattern. Is that correct?
Probably, I have no evidence of that, but doctors' hands are tied, as with the opioid prescriptions, So now they have strict limitations, but they can give only for X number of days. I think it is like 7 days prescription, and after that, doctors are not supposed to be providing the opioid prescription unless there is a strong evidence. So probably, after the prescription ran out, so people are reaching out to the street drugs, So unfortunately, that street drug which they are reaching out to, the cocaine or heroin or the pressed film for that matter, or that oxycodone which is available on the street could be tainted with the fentanyl, So that's the reason why. Could be, So there is no strong evidence, but it could be one of the reasons, So people, they ran out of the prescription and they are running into the street for the drugs.
Yeah, because to add to that, Brian, again, it's kind of figuring out the chicken and the egg situation here, to your point. Is it that these individuals started taking these prescriptions in the doctor's office, they get the 7-day, they get hooked, they go seek it out on the streets, or is it they're already hooked on it from the streets, they go see these doctors to see if they can supplement it accordingly, and then they're still jumping back out in the streets and then get exposed to fentanyl, which is obviously one of the bigger mediators in the actual mortality. But just looking at it from the chain, in terms of getting to the early part of the chain to stop it, I mean, it still seems like there's the doctor's a major component, or if not culprit, for that too. So it's just something that I thought was very interesting. But yeah, figuring out the chicken and the egg would actually be a very interesting study.
Exactly, So, but when we are collecting the circumstantial data, the major number of people already had the substance abuse problem or the mental health problem, So prior to the overdose. So what does it tell you? So the problem was already existing, and this person has overdosed, unfortunately, on fentanyl, and they were not able to survive. So it is very hard to say it is the prescription beginning or because of the people are using the street drug and then they are dying. So it's a chicken and egg. Unfortunately, there is no. We can go and talk to the dissident. So what pick their mind. So we would, at least currently, 30 days before the death of each dissident, only 7.9% of the people had the authentic doctor's prescription. But rest of the 80 plus point of the people, percent of the people, they didn't have any opioid prescription.
Okay, thanks for clarifying.
Yeah. Any questions?
Does anyone else have any questions for Shobha? Okay. Thank you all for taking your time today during your lunch hour to be here with us to listen to this great information, important information. So on that note, everyone, please have a wonderful day, happy hump day, and have a great rest of your week. And thank you, Shobha, for
Thank you very much.
Today.
As I mentioned, I will be sharing the slides, maybe next couple of hours, okay? I have some other meeting to attend. Then right after that, I will convert into PDF and then share with you. So you can share with all the